So let me just describe this framework. And the first thing to think about is that it's actually intended to run right across the continuum of care. So that's important to understand before you look at it. So at any point in the woman's or the baby's or the family's journey through pre-pregnancy, pregnancy, labour birth and afterbirth in the early weeks, this is the way in which the care should be provided. So starting at the top of the framework, first of all you can see that the green boxes, if you like, on the left-hand side are care that all women and all babies should be receiving. So that's right at the top of the diagram. The first set of categories, if you like, is practice categories. It's the what is being done that's going to help women and babies. And we've divided those into categories that move from the very basic education, information, health promotion, that basically women can do for themselves. So this is information about nutrition, it's information about breastfeeding, it's information about services that they might use. So it's very much about how women themselves can be healthy and prevent problems. So that's the very first category. The second category is about assessment, screening and care planning. So that's what the care provider is doing with the woman to assess how her health is, how her pregnancy is developing, whether she's developing any problems, screening for HIV, for example, other diseases, screening for anemia, so that if there are problems, appropriate referral can be made in a timely way before something becomes an emergency. And during that process, of course, the woman herself becomes aware of what her circumstances are. The third of those categories for all women is the, if you like, the care that will prevent complications happening. A very simple example of that is encouraging women to walk around in labour instead of lying down, so that we know that that encourages labour to progress, or continuous care throughout labour, so that the woman is confident and has that help right to hand when she needs it. So there's ways of preventing problems, and if the care is put in a timely way, again you can prevent those problems escalating. So those are the three practice categories in which all women have needs, all babies have needs, so that care is right there for them. Then over towards the right hand you get two smaller boxes. Now they're smaller because we should have less women needing care in those boxes if we get the supportive and preventive care right. That's what the evidence is telling us. So the fourth box is, if you like, first line management of complications. So this might be external cephalic version for a woman with a breech presentation in pregnancy, so that she has a better chance of giving birth, a cephalic presentation with the head first, so to prevent problems. The fifth box is where you get into the specialist medical obstetric neonatal services. So this might be caesarean section, it might be blood transfusion, it might be neonatal care for a very preterm baby. So it's where you need the highly trained specialist medical practitioners in that fifth box. So if you like, those boxes are progressively smaller because we're assuming in all of that, if that preventive and supportive care is in there, then fewer and fewer women will need those specialist services. So those are the practice categories. That's what's done to women. The rest of the framework explains how that care should be delivered. So the next category down is around the organisation of care. Obviously those services need to be available to women. They need to be accessible, they need to be appropriate, and they need to be good quality with adequate resources and a competent workforce. More than that, They need to have continuity across for the woman and the baby and the family wherever they are, home, community centre, hospital, so that they're not getting different care in different places, but that there is an understanding of the woman and the baby's needs across and integrated between those facilities. The next level is looking at the values, if you like, the value set of the health system. So that's about good communication, that's about respect, respectful care for women, for babies, for families. And it's about tailoring care to the individual needs of the woman and the baby. You know, the one size fits all approach doesn't particularly work, because you end up doing things that women don't particularly need, or you end up not doing things that they do need. A woman living in a situation of domestic violence, a woman with a mental health problem, a woman with concerns that her pregnancy isn't developing well, a woman who has HIV infection, they all have very, very, very different needs. A woman who's progressing really well and is very healthy and is likely to have a completely straightforward birth is different from another woman who might have had a complicated birth before, and that there's reason to think that she might have a complicated birth again. So we're saying that care should be tailored to individual needs and not just one size fits all. The next category down is around what we're calling philosophy. And this is a really important category at the moment in terms of maternal and newborn care. And it's possibly the one that's been least considered in planning services. And it's very much about optimising normal processes, not interfering with what's happening for the woman's body and indeed the baby's ability to adjust and develop. So it's about thinking about normal biological processes, how the woman's body is and how capable she is of giving birth herself, for example, or breastfeeding herself. Social processes, cultural processes, how she is in herself, and really building her own strengths and her own capabilities. So you're not doing two, you're not taking away her ability, you're not taking away her own empowerment. You're saying, we're caring for you to strengthen what you are able to do. Even if a woman has complications, she still has also lots of capabilities. And so it's strengthening what she is able to do, even if she needs help in other ways. The final piece of the framework is around care providers. And whatever professional group that is, they need to be competent, they need to be skilled, they need to be working in an integrated way with others, so that you don't say this group has, kind of working on its own, or you need to make sure there are good referral links, good systems across and between different care providers. They also need to be culturally competent, back to this one size fits all, if you like, but to understand if a woman is coming from a very poor community, if a woman is coming from a very affluent community, if she belongs to one or other ethnic group, if she's very young, if she's older, it's her first baby, it's her sixth baby, if she's having twins, whoever, there is an understanding and a cultural fluency that you would understand what she needs in terms of how she would like this birth to happen, how she would like this pregnancy to go, and how she would like to care for her baby. So those competencies are needed actually in every caregiver, whoever those are. And although we then go on to examine the evidence, and we find that midwives, not surprisingly, are the group that are most prepared, most skilled, most able to provide the whole range of care across the framework within an integrated and skilled workforce as a whole. One of our arguments is that everyone caring for mothers and babies and families throughout that period should be able to provide care in that way, respectful, really acknowledging women's own capabilities and supporting those, and trying to prevent problems as well as treating them. So it is that whole picture, if you like, the integrated care, the what, the how and the who, that the framework is really presenting as the evidence-based way in which health systems should be providing care for women in high and middle and low income communities to really achieve the important outcomes that we know can be achieved. Because actually once we did that analysis, we then looked at the outcomes that the care would improve if it was provided in that way. And what we found was over 50 outcomes that would be improved if women had care provided in that way. Those outcomes would be clinical outcomes, they would be psychosocial outcomes, they would be outcomes for mother and baby. We would see improved survival for mothers, we would see reduced stillbirths, we'd see improved survival for babies, we'd see improved breastfeeding, and we'd see ongoing benefits for psychosocial outcomes as well. And perhaps not surprisingly, given that, we would also see an improvement in the efficiency of the organisation, if you like. There would be resource savings, organisational benefits as well as the obvious benefits that we identified for mothers and babies and families from analysing that evidence in that way. So it's a pretty powerful foundation for the rest of the series. But the framework also has strong messages for health systems about how they should think about planning services. There's strong messages for educators about how you prepare students to work in that way. And there's strong messages for people who assess the quality of a system, who monitor, because it allows you now to distinguish between different components of quality care and to identify them specifically and analyse those elements of quality care to see if they're there in the care that you're providing. It's quite possible that some systems are doing the right things to women, the right practices, but not necessarily in the way in which we'd like to see them provided and the evidence suggests is most effective. So without continuity or without respect, for example. And what the evidence is saying is that you do the right things, but you do them in those ways and with that organisational framework and with care providers who really understand that kind of care. So it's now out there for people to look at, to think about, to test out, to comment on, to criticise, to develop, to make it better, to evolve it over time. But at the least it's out there for people to think about and to stimulate debate and conversation, to inform future research, to say, okay, let's test it out, let's see what happens when we test it out in different settings, in different countries, with different population groups, and so on. It's out there for people to use and, take forward and make it better into the future.